colleagues who are present and are
This
attended.
meeting is being recorded.
Hello, those who are present and assembled here in the virtual platform. Today, my topic is typical ultrasonogram appearance of common pathologies in the adenocarcinoma. My contents of the presentations will be like this: classification system for adenocarcinal pathology, ultrasonogram features of common benign adenocarcinal pathologies, standardized iota simple descriptor, prediction of malignancy by iota simple rules, iota adenous model. At the end of this lecture series, you will be able to compare the differences between typical, normal, and common abnormal appearance of adenosine in gynecological ultrasonogram examination. The key points where we can discuss: how do a normal ovaries typically look like? What are the typical ultrasonogram appearance of the most common pathologies in the adenocarcinoma? What diagnostic methods can I use to discriminate between the benign and malignant adenocarcinal pathology? Which patient I should refer for a specialist opinion? Many of time we get a report like complex adenocarcinal mass or complex ovarian mass. But does it help us? It does not really help us in the management of our patients. By the end of this presentation, I hope you all will be able to report this type of pathology in a proper format. By the time, what is an adenocarcinoma? A adenocarcinal mass is a part of an ovary which is not consistent with the normal physiology. Then we call it an adenocarcinal lesion. Here in the left down corner of your my presentation, there is a circumscribed mass with a acoustic shadow which represents a dormoid. This is not a normal physiological finding, then it is a lesion. Similarly, another mass in the upper right corner, that is a circumscribed mass with some clot inside, but it looks like a lesion. It looks like a mass, but it is a normal physiological changes of ovary. So it is not a lesion. So dormoid is a lesion. Corpus luteum is not a lesion. The adenosine could be a uterine mass, could be ovarian mass, could be a parabrian, could be a tubal, and sometimes some non-gynecology masses may present in ultrasonogram as a adnexal mass. But 90% cases, the adnexal mass is represented by ovarian mass. So we will concentrate mostly on the ovarian findings in adnexal mass. In this adnexal mass, we'll discuss about what a normal ovary looks like, what a functional cyst looks like, what are the benign tumors, common benign tumors that we see in our ultrasonogram, and rest the borderline tumors, invasive tumors, and metastatic tumor, how we'll diagnose by iota simple rules and descriptor we'll discuss. Coming first to the what is the normal ultrasonogram finding of a ovary. As you know, ovary is not a static organ. It is a dynamic organ. Not only it changes its shape and size before menstruation, during the reproductive period of life, and after menopause, it also changes throughout the menstrual cycle. During the first period of proliferative stage, and during the mid period of proliferative stage, during just before ovulation and after ovulation. Continuously the ovary changes its shape and shapes, and also due to the physiology we can see the changes in the menstrual ovary, and we can diagnose by the ultrasonogram. The size, shape, and ecostructure of ovary we should discuss. It is usually located by the side of uterus, and if at all we are not able to diagnose, iliac vessels may guide you to where the location of the ovary, and it is a reliable landmark for the location of the ovary. Ovaries are imaged as a homogeneous hypoechoic oval structure with slightly echogenic central part. The ovarian follicles facilitate their sonolucent areas, some starting from 2 to 6 millimeter at the first period of proliferative age, and that helps us to identify the ovaries in the pelvis. So, as I have told, the ovary size changes throughout the period of a woman, and it is during normal reproductive period, the median volume of the ovary is around 7 millimeter. It is an ellipsoid structure. It measures around 3 centimeter and 2 centimeter and 2 centimeter, and the volume calculated can be by length by width and multiplied by depth and multiplied by 0.5 to 3. So it comes around 6 to 10 centimeter cube, and maximum volume of a ovary can be 14 to 16 centimeter cube in a reproductive period of a life. Coming to the how many follicles are present in the ovary. Actually, previously, as per the textbook, there are 6 to 7 follicles are present. But as we advance in the science and we are having newer and very developed gadgets, we are able to locate more than 10 to 12 follicles, and sometimes around 20 to 36 follicles can be observed in one ovary. Previously, the patients can be diagnosed if the ovary contains more than 12 follicles. Now it has been risen to up to around more than 20 follicles per ovary. As we are having three-dimensional figure of ovary, we can calculate, we can count more number of follicles in ovary. And after menopause, the number of follicles disappears. So as the follicles are not present in the menopause, it becomes difficult to identify a menopausal ovary, as it is shrunken in size and also does not have any active follicles. So how big is a normal ovary in a postmenopausal woman? It decreases in size, and there is loss of any follicles is there. In postmenopausal, detection of ovary is difficult due to lack of follicle and small size of the uterus. As I have already discussed, not only the ovary changes in size during the different phases of woman life, it also changes during the same menstrual cycle. And during just after menstruation, there will be few small follicles may be there, and 2 to 3 follicles out of them gets recruited in the first phase of proliferative phase, and some before ovulation, one becomes dominant follicle, rising to a size of around 18 to 20 millimeter, and after the earliest shows the dominant follicle ruptures and it becomes a corpus luteum, and the corpus neoangiogenesis occurs within 24 hours, and there may occur a ring of hair within. Similarly, as per the ovarian changes, the endometrium also goes into the pre-ovulatory 3-layer, and also after the ovulation it becomes hyperechoic and trilaminar layer, suggestive of ovulation and the secretory phase of endometrium. So not only the ovary, the endometrium also changes throughout the menstrual cycle. So after ovulation, you can have some amount of fluid in the pouch of Douglas, and that is normal. And if there is small amount of, it can be measured by longitudinally. And if some amount of fluid in the pouch of Douglas is absolutely normal, and if you found any amount of fluid in the uterovesical floor or any other part of pelvis, that is abnormal. But in presence of some amount of fluid in the pouch of Douglas is normal. During early follicular phase, the few follicles grows in size, and after ovulation, there will be some amount of fluid in the pouch of Douglas occurs, and there occurs corpus luteum appears in the ovary. Corpus it has been seen that corpus luteum may present as a different, it may appear to a sonologist as a lesion. So you have to, in a reproductive phase of life, if you find a adnexal mass, you have to differentiate that either it is a normal physiological corpus luteum or any pathology is there. So you can have a variety of looks of corpus luteum, and normally commonly it is seen as a thick hyperechoic wall enclosing some amount of hypoechoic content. But after 24 hours of ovulation, there may occur neovascularization, and there may occur a ring of fire around the corpus luteum, which may look as a ectopic pregnancy, may confusion with ectopic pregnancy. And during ovulation, some amount of bleeding occurs into the corpus luteum, but that actually gets absorbed during the course of time. If there is a large amount of bleeding inside the corpus luteum, it may present as a hemorrhagic cyst, and there will be a lot of clot present inside the corpus luteum cyst, and it will take some time to get dissolved. So we have to follow this patient after some times, and if you think that this is not a lesion, this is a corpus luteum and it is a clot, you have to give a pressure on the probe, and the clot will move like a jelly-like movement, and there is and it will, after 6 weeks or 4 weeks, if you ask the patient to come and again repeat, then you can see that this clot returns and this cyst changes its shape and size. So after the normal oval, we'll now discuss about what are the functional cysts of the ovary. The common functional cyst of ovary is a follicular cyst. It is a simple cyst. This is most common type of ovarian cyst. It results from the growth of the follicle. The follicle is a fluid-filled cyst and contains an egg. In some cycles, this follicle grows larger than normal and does not rupture to release the egg. Normally, it results with simple observation over the course of days to months, and its size is usually less than 10 centimeter. Usually, this type of follicular cyst results by giving OC pill for 3 to 6 months. The next type of functional cyst is the corpus luteum cyst. I have given applied color to the corpus luteum. This is corpus luteum. There is ring of fire, and this is actually if you put Doppler on it, it is usually less than 3 centimeter diameter, and it has a thick wall, and it contains sometimes low-level internal locus suggestive of hemorrhagic cyst. I have already discussed that corpus luteum may look different, and if you give pressure on the probe, and there will be a jelly-like movement on release of pressure, and if you apply color Doppler, it appears solid. So if you apply color, then there will be no color because the clots are avascular. They don't have any live cells, so it will not have any blood flow inside it. Again, another thing is that the septa which found in the concavity of the margins are faces to inside towards the lumen, and after 2 to 3 weeks, if you again repeat the ultrasonogram test, you may see that the clot retracts and the size decreases and it changes with time. Now moving on to what are the benign tumors of ovary. The most common benign tumors of ovary that we encounter are dermoid or mature teratoma, endometrioma, serous cyst adenoma or mucinous cyst adenoma, serous cyst adenofibroma or mucinous cyst adenoma. So coming the first most common and easily diagnosed cyst tumor, benign tumor is the dermoid cyst. Usually it occurs in a premenopausal woman. It contains fluid, fat, and solid tissue. This gives a typical stereotypical sonography picture, and the dermoid plug which contains the hair and the teeth or fat that causes acoustic setting, causing the matted hair and the sebum cast an echogenic shadow, and that is typical of dermoid cyst. Another thing you can find in a dermoid cyst is that fat fluid level, also known as hair fluid level or fluid level, is seen to be believed to be the result of layering of serous fluid along with the sebum. So this is the there will be a circumcised mass with a hyperechoic mass which suggestive of mesh-like structure. This is echogenic foci that consists of small hairs floating inside the cystic fluid, that is sebum or fat. Next common benign tumor we encounter is endometrioma. The classical example is a unilocular cyst with acoustic enhancement. The cyst contains a ground glass appearance, homogeneous ground glass echoes as a result of hemorrhagic cyst and debris, and it also have different looks in the different phases of its collection of blood inside the endometriotic cyst. The third most common is the cyst adenoma or cyst adenoma. Usually it is the most common ovarian cyst that is encountered in a premenopausal woman. It is a unilocular anechoic adrenal lesion. Some papillary projections mostly absent. If it is present, it should be less than 3 mm. If there is any wall irregularity, it is thin with an acute angle with the cyst wall and has a regular surface. Some lesions may contain sonographical dictated septation, but there should not be any flow dictated in the color Doppler on the cyst wall or on the septum. The most uncommon or very rare tumor, benign tumor that may encounter in ovary is the fibroma. On ultrasound, its texture is mostly like a fibroid of uterus. It is mostly manifests as solid hypoechoic mass with ultrasonogram beam attenuation. This is another condition where there will be acoustic shadowing apart from the dermal cyst. Again, fibroma also causes acoustic shadowing. As such, they may appear similar to pedunculated subserosal fibro. However, the sonography appearance can be variable, and some tumors can rarely have cystic component also after degeneration. So these are all the common benign tumor, ovarian tumors we encounter. Coming next to the common extra-ovarian adnexal pathology, and what we encounter is hydrosalpinx, hydropiosalpinx, parabrian cyst, and peritoneal inclusion cyst or pseudocyst. Hydrosalpinx is typically there occurs sausage shaped. It is elongated cystic mass. If there is a infection or there is a hydropiosalpinx, there may appear as a cogwheel or beads and sting like appearance. And the beads and sting appearance are due to the endosalpinx folds which viewed as a cross section. And the sausage shaped are due to the S-shaped cystic masses due to collection of the fluid or blood or pus inside the fallopian tube. Uh, these are, if you see, by ultrasonogram, these things will be elongated, masses will be there, but there will be a septa. But after careful observation, you will see the septa is not complete septa because it does not touch the other wall also. So it is due to folding of the fallopian tube on itself that it looks like a cystic multilocular cyst. But if you carefully observe that the septa does not touch the uh, other wall also. So this is the incomplete septa. So we consider that hydrosalpinx pyosalpinx is a unilocular cyst as there is no complete septa. The west end refers to diametrically opposed indentation along the walls of tubular cystic structure, and that is characteristics of hydrosalpinx. This hydrocephalus dilated serpentine tubular structure in the pelvis, but if there is a pus or blood inside, there may be low-level echoes due to higher protein content of the debris within the tube that distinguishes pyosalpinx from the hydrosalpinx. The content inside the pyosalpinx will be more echogenic level or low-level echoes may be found inside. The next common thing is the para-ovarian cyst. Para-ovarian cyst arises from the by the side of the ovary. It is not an ovarian mass, and it is a complete. Its physiology and its management is totally different from the ovarian cyst. So it has to be clearly distinguished whether it is a ovarian cyst or it should be a para-ovarian cyst. It para-ovarian cyst appears a round oval cystic mass located close to the ipsilateral ovary. But if it is an ovarian mass, it appears like a crescent shape. Means up the ovary appears to enclose the mass in a ovarian mass. But here there will be a sliding sign will be positive. If you give pressure on this on your probe, then the mass appears to separate from each other, and you can have a thick mass, thick space between the ovary and paraovarian cyst. So though it initially appears that the mass appears to arise from the ovary, and if you look for the crescent sign or sliding sign, it will you can able to differentiate whether the mass belongs to ovary or it belongs to the paraovarian mass. So these are the paraovarian cysts that can be confused. Next is this peritoneal pseudocyst. Peritoneal pseudocyst means it does not have any mass. It is a peritoneal collection due to some infection or chronic period or previous surgery, and it appears as a mass or it appears as an ovarian mass. And actually, if you do a transvaginal ultrasonogram, the ovary will be the normal ovary or volume of the ovary or morphology can be seen separate from the ovarian cyst, from the peritoneal pseudocyst. It resembles like a spider in web, and it is a lot of you have to do a lot of tests, and there the usually this septa, if you carefully observe, the septa is not from the from the it will attach to the bowels and other part of the omentum. It doesn't attach to one part of the ovary. So if you in this case, you have to carefully locate or identify the ovary separately, and then if it is separate, then you have to see where the septa goes from where to where. If the septa attaches to the bowel, then it appears to that it is not a ovarian cyst, it is a ovarian peritoneal pseudocyst. So we have already discussed what a normal ovary looks like, what a functional ovary looks like, what are the benign tumors of ovary and what are the non-ovarian benign tumors of the adnexal. Now we have to discuss about borderline tumor, invasive tumors, and metastatic tumors. And when we have such type of ultrasonogram pictures in our ultrasound table, it is really difficult to report this type of report this type of adnexal mass, and most
Indira
commonly
madam, go back to the previous slide and stay there for some time. Actually, the previous slide. Yeah. This is important. Multi-locularity wall. This is the thing you have to emphasize.
Yes, sir. I will discuss it because I will discuss it all these things in the how we will diagnose, how we will morphologically classify, how will muscularly describe this type of lesions. I'll discuss it in my next slide.
Thank you.
So, does the reporting of an adnexal mass really matter to a surgeon? Yes. As a surgeon, I must tell that when we are getting a report like this, many questions comes to our mind, whether this mass is a physiological or it is a pathological, whether I am going to observe this mass for some time and again repeat it after 6 weeks, whether I have to operate it or not to operate or observe it. If I will operate, what type of surgery I will prefer, whether I'll go for a laparotomy or a laparoscopy. If at all laparotomy, what type of incision I should give? I should give a longitudinal incision or a transverse incision. If at all I will give a transverse incision in a ovarian malignant, that it will be a very great mistake by me. So whether at our center I can do this surgery or I'll refer to this patient to a oncosurgery. So many questions comes to us in our mind, and to decide what for the next management. And with the help of so many of advanced guidelines and outer consensus guideline, now the ultrasonogram is able to say you what is the nature of mass, whether they physiological, is it infective or endometriotic or neoplastic, whether it is a benign or malignant. And sometimes if it is a dermal cyst, you may able to give a histopathological diagnosis. So it is possible. How? There are so many diagnostic methods to discriminate between a benign and malignant adnexal pathology. Clinically, we do a clinical examination. We see for the abdominal mass, what is its mobility and fixity, and what is the consistency of the mass, and do a Doppler imaging and do the RIPI. Previously, when I was the postgraduate student, at that time, we are having many theses regarding the RIPI of the septum or mass as a indicator of malignancy. The morphological scoring system is there. Another, we are sending CA125 He for other tumor markers, that is also available with, and RMI and Roma also there. Clinically, we also apply this time, but I know it is now not much used, but still sometime in a medical college we are using this. Now the potential to diagnose the benign and malignant is mostly done by iota simple descriptor, iota simple risk, and iota adnexal model. Thanks to the Timmerman and et al. For standardization of terminology for describing the morphology of a adnexal mass by Storm's definition as a measurement to describe the sonographic feature of adnexal tumors, and they have given us a consensus opinion for the international ovarian tumor analysis to help us to diagnose or determine whether the mass is a benign or a malignant. Why do we need a iota guideline? Is it really helpful? Yes. Appropriate treatment requires a proper diagnosis and requires the use of standard terminology to describe ultrasonogram finding. And when you know that if the terminology is standardized throughout all over the India, all over the world, so that we can understand the report given by sonologists by all over the world same, and we read the same language, that we understand the report each other in the same way. And by ultrasound, we can compare the scientifically describe the morphology of the mass. Everybody, if there is a guideline or consensus, we can describe a mass in a how it has been characterized. And Try to ascertain the origin of the mass, where it is, whether it is from the ovary or from the fallopian tube or from the Parabrian tissue, and try to ascertain the histology. And in all cases, we must try to ascertain the likelihood of a malignancy is there or not. So before going for iota simple descriptor, iota has standardized definition and terminology. We must know how to describe a mass. Then only you can go for the iota simple descriptor or simple rules. There are 6 ultrasonogram variables to describe a mass. Whenever you get a adnexal mass, you must think of the 6 ultrasonogram variables to describe a mass. What are these 6 ultrasonogram variables? One is the morphology of the mass, then is the what is the content of the lesion, and whether the presence of papilla or solid mass is present, what is the vascularity of the lesion, whether the lesion is causing any acoustic setting, and ascites is there or not. So coming to the first morphology of the lesion, there are 5 different morphology. You can describe all the masses, whatever you see, you can describe all the masses under these 5 heading. One is unilocular, second is unilocular solid, multilocular solid, or solid. So whenever you get a mass, you have to, whenever you are doing a sonography, you have to keep it in mind, I will describe this mass under these 5 headings. So how a unilocular mass looks like? Unilocular mass is a simple, there is no septae, it is a circumcised lesion. It contains anechoic fluid. And as I have already described that a hydrosurfing is also a unilocular mass because the septum is not complete. So a unilocular mass looks like in this ultrasonogram, and it has been abbreviated as UL. The next thing, unilocular solid. There is a unilocular cyst is there, and one part of the cyst wall contains a solid mass. So it appears like this, and it has been abbreviated as US. The third common morphology feature is multilocular. There is a cyst, and the cyst is divided into multiple septae inside. So it may be 2, 3, or 5, or more than 5. There will be multilocular cyst is there. And there is a multilocular cyst here there, and one of the side is containing a solid mass. So it has been abbreviated as multilocular solid. So it is a multilocular. There are many locules are there, along with a solid mass is there. And the fifth last morphological classification is the solid mass. When you get a mass, if 80% of this mass is around, it is a subjective assessment of the mass. If the 80% of the mass is solid, then you consider this mass is a solid mass. You may have some 10 to 30%, 20% of mass with the cystic component, but you consider this is a solid mass. So these are the 5 morphological classification of a mass. Next is the content of the cyst. Aorta does not give any relevance or any importance to the content of cyst as long as the malignancy or benign is concerned, but it defines what is the content of cyst. A content can be anechoic, like a serous cyst adenoma. There is clear fluid is there. It appears clear that it is anechoic. It may be a low-grade echogenic mass is there, like mucinous cyst adenoma. You may get a small hypoechoic collection inside the cyst, that is low-grade. Ground glass appearance. If you say ground glass appearance, it is mostly seen in the endometrioma. There will be mostly hyperechoic collection inside that appears as a ground glass appearance, and hemorrhagic cyst in a corpus luteum. And sometimes you may get a mixed hyperechoic, hypoechoic, and anechoic collection inside the cyst. So these are the content. So first you describe what is the morphology of mass. Next you describe what is the content of the mass, and then that third thing you have to describe what is the solid component. According to iota, a structure that has echogenicity suggestive of tissue, but the white is considered as a solid tissue. What according to iota, what is not a solid tissue? It is not a solid tissue. The white ball of a dermoid is not a solid tissue. The blood clot or the mucin inside a cyst, it is not also considered a solid tissue. So solid component is a tissue that has a structure and that has echogenicity is called a solid tissue. In papillary projection, if the projection is more than 3 millimeter, then also it is called a solid mass. And if the projection is less than 3 millimeter, it is called the cystual irregularity. And the papillary projection should be measured from the inner wall of the cyst to the tip of the papilla, and the cyst wall should not be included during the measurement. So if it is more than 3 millimeter, then you consider that papillary projection as a solid mass. So what not a solid component as per the data? Clot or debris in a cyst, echogenic white ball or hair or sebum in a dermal cyst, mucin in a cyst. That is should be considered that not to be considered as a solid component. When you find a clot and it appears as a solid mass, it has to be differentiated from the clot from the solid mass. If you give a pressure, the clot shows a jelly-like movement on release of pressure by the probe, and it is usually avascular because it's all dead tissue, and the margin facing the lumen are concave and may not be attached along the entire length of the wall. And the appearance, if you do it after 2 to 3 months, it changes with time. Then walls and septation, that is also not given much importance by the aorta, but solid, if you are examining a solid mass, you should look to the external wall of the mass so that you can consider that mass is regular or irregular. The external wall of a solid mass, if it is regular, then the mass is regular. If it is irregular, then it is irregular. When you are examining a cystic mass, you look into the inner wall of the mass. If the inner wall is smooth, then the mass is regular. If inner wall is irregular, then it is irregular. Regular margin usually tells us that probably this mass is a benign. When the mass is irregular, probably the mass is benign, malignant. And what is septation? Septation are sheet of tissue originating from one wall and going towards another wall, and it is usually if it is less than the thickness of the septa is more than 3 millimeter, it more likely malignant, and if it is less than 3 millimeter, it is usually benign. The fourth thing we consider, first is the morphology, second is the content, the third is solid, the fourth thing is the Doppler flow. If there is a solid area, you can see Doppler on the wall of the mass, on the septae or papillae, and you can put the Doppler on it, and it has four scores. Color 1, Doppler score 1, it has no flow. If his minimal flow, his score is 2. There is moderate amount flow, then his score is 3. If there is abundant flow is there, then his score is 4. And 3 and 4 are suggestive of the malignant tumor, and 1 is suggestive of it is benign, on 1 or 2 is benign. Apart from the color index, we can go for the RI-PI of a mass. If it is malignant, the RI may be less than 0.4 and PI may be less than 1 due to less vascular resistance in the malignant region. Again, you see what is the location of the vessel. If you find more abundant flow in the middle of a mass, center of a mass, then probably it is a malignant lesion. And if you find vascularity only around the margin of the mass, then peripheral part, then probably it is a benign. Presence of flow confirms that it is a solid tissue, and absence of flow in a solid tissue occurs in torsion. Even if there is torsion, if there is solid mass, if it has undergone torsion, or if your machine has a defective setting, if your PRF is not properly settled, even if there is a flow inside, your machine is not able to pick up the flow. So you have to change or you have to adjust your PRF in the machine so that you can pick up the flow. The fifth thing is the acoustic setting. Acoustic setting, presence of acoustic setting is a benign feature, it is a good thing, and it appears in a dormant fibroma, and behind papilla of benign Cyst Adenoma fibroma, you can get a acoustic setting. Acoustic setting is that you get loss of echoes beyond a sound observing structure. Here the dormant mass that is consist of sebum, tooth, or the hair that causes a mess, and beyond that there is loss of echo occur, and there will be acoustic shadowing. Acoustic shadowing is a benign, suggests as a benign lesion. The next sixth number is this ascites. You know, I have already discussed that presence of some amount of fluid in the pouch of Douglas is a normal finding, but if you find fluid in the intravesical fluid or in the on the peritoneum or in the pouch beyond the pouch of Douglas, then it is suggestive of ascites. And if there is a ascites is there, it is suggestive of a malignant lesion. So after having a standardized morphological description of the mass, then you have to you have to go for the diagnosis or classify the mass as a what nature of the mass, whether it is benign or malignant. For this, you have to go for a step by step. First step is the simple descriptor. What is simple descriptor? The RTA has three-stage approach to diagnose a mass, whether it is a benign or a malignant. The first step is simple descriptor. The second stage is simple list, and third stage is Adnesen model. Most of the 46 to 45% of masses you can diagnose by the simple descriptor. It has a high sensitivity and specificity, and those masses which cannot be diagnosed by simple descriptor, we can apply the iota simple list. And most another 25 to 30% masses that can be diagnosed with iota simple list. And remaining 18 to 20% masses which cannot be applied by sample descriptor or iota simple list should be subjected for Adnesen model or to a referred to a higher center for the diagnosis for the second opinion. So what is first thing is the simple descriptor. The certain abnormals are really obvious. If you see a person from her walk or from her dress sense, you can know this is Masha madam, this is Mala madam, like this. This is simple descriptor. You see from distance, you can recognize a person, you can recognize a thing that is simply you can know what is simple descriptor. There is certain abnormality or certain things are really obvious. You need not to do anything. Just only seeing this thing you can diagnose. That is called pattern recognition. And there are four benign parameters in this simple descriptor and two malignant parameters. What are the four benign easy descriptor or simple descriptors are there? One is if you find a unilocular mass and which contains ground-glass appearance inside the cystic component, you readily diagnose that it is a case of endometrioma. If you find a unilocular cyst with mixed echogenic and acoustic shadowing, if there is acoustic shadowing there, unilocular mass, you simply diagnose that it is a dermoid. If you find only unilocular, there is cyst is there and the content is anaerobic, then it is a serous cyst adenoma. Remaining unilocular cyst with regular wall may be a hemorrhagic cyst, maybe a corpus luteum, that is physiological cyst. So these are the four iota easy descriptor which you can diagnose once you see the mass. At once you can diagnose. What are the iota simple descriptor? There are two malignant parameters in the iota simple descriptor. In a postmenopausal, if there is a solid mass or ascites, and if there is a mass with moderate to abundant flow, if the mother or if the age of the patient is more than 50 years and CA125 is more than 100 international unit per milli, then it is a malignant features. So if you have a postmenopausal woman with a solid mass in the ascites, so easily you diagnose this is a malignant tumor. So these are the four simple descriptor benign markers and two simple descriptor malignant marker. If at all there is a mass in your ultrasonogram screen and it is not fit to this type of simple descriptor, then you go to the step 2. The step 2 is the outer simple rules. When simple descriptor do not apply, if the mass is not instantly recognizable, no, it is not an endometrioma, no, it is not a dermal cyst, nor it is a serous cyst adenoma, not it is malignant, then you apply simple rules. Simple descriptor do not apply, then apply simple rules. So there are 10 simple rules, 5 malignant parameters are there, and 5 benign parameters are. The malignant parameters are ascites, fluid outside the POD, irregular solid tumor. I have already told solid tumor, the mass of solid is more than 80% solid, and at least 4 papillary structures are there. 4 solid structures are there irregular multilocular solid, and the largest diameter is more than 10 centimeter present, and you are having a strong blood flow color score more than 4, then it is a malignant feature. And coming to the 5 benign features of simple rus are unilocular, no solid mass is there, unilocular solid, but the largest diameter of papillary is less than 7 millimeter, and presence of acoustic shadowing, and smooth multilocular cyst is there, but the size of cyst is less than centimeter, and there is no color profile or color score G1. Then this is a benign tumors. Again, coming at what are these B features? With the benign features are these are the 5 B features are there. One is unilocular cyst. Second is presence of solid component, but it is less than, there is a solid component, but the diameter of the solid component is less than 7 millimeter. This is 7 millimeter, and presence of a acoustic shadowing. You see there is acoustic shadowing is there, so it is a benign tumor, and there is a multilocular. There is septa is a multilocular cyst, but the length of the so it is a smooth, and length of the largest diameter is less than 10 centimeter. And you apply color, if the color score is 1, then it is all are B features or benign features. Similarly, coming to the malignant features, it is irregular and solid tumor. Presence of ascites is there, and at least 4, 1, 2, 3, 4, 5, 6. There are 4 papillary structures, more than 4 papillary structures there, and there is irregular. The margin are irregular, and the mass size is more than 10 centimeter. And you apply color, and there is abundant of mass also. Then it is a M feature of mass. So these are the in one slide, all the complete benign features are there, or all the 5 malignant features are there. M features are there without the presence of any B feature, then you diagnose this mass is a malignant. If you find any of the features, one of the B features is there, any of the M feature or